going to spend the morning going over anxiety disorders. Because how many of you would like a review of some anxiety disorders? Right? I hope, right? Because it would be stupid for me to get right into the treatment. So I'm going to spend some time going over the anxiety disorders in a little bit more detail, and then I'm going to get a little bit into a differential diagnosis and assessment, and then the treatment. Okay, so this is the cartoon, which I happen to love this cartoon. It's the father saying to the son that says, stay away from the gangs, don't talk to strangers, be careful breathing the asbestos, be sure to wear your flak jacket, say no to drugs and sex, don't get lost in the overcrowded classes, don't get stabbed or shot, study hard, and have a nice day. So, you know, it's again, I don't know if it's as funny the second time around, but, you know, this is what we're talking about. Similarly, isn't 7 awfully young to be concerned about global warming or terrorism or whatever, you know, whatever it might be? And so this is the overview. I'm going to talk about the prevalence of anxiety disorders, diagnosis and assessment, theories of etiology, overview of treatment, nuts and bolts of the treatment, and then cases and questions, but we can intermingle this throughout. Okay? Okay, so we already said this yesterday, that it's the most prevalent of problems. So some of this I can go over fast. And this is to make the point that it's even more common anxiety than conduct problems, if you look at the bottom. And I told you, it hovers around 10% in the population. Bless you. And, oh yeah, great, already a question, good. The reason is because this is an old slide from 1987. It used, in the DSM-IV, there was a category called anxiety disorders of childhood and adolescence. It contained separation anxiety, over-anxious disorder, and avoidant disorder. When DSM-IIIR came out, they got rid of over-anxious disorder, and they said everybody's just generalized anxiety disorder now. And they got rid of avoidant disorder, and they said everybody's just social anxiety. So that is why there's now only one disorder that's specific to childhood, and that's separation. It used to be separation, over-anxious, and avoidant with children. So when I started my career, I was working with over-anxious, separation, avoidance, and all the other disorders. And then we had to like change and say, okay, there's no more avoidant, there's no more over-anxious. But that's a very good question. We know that anxiety disorders is one of the earliest disorders of childhood, and it could begin as early as 4 or 5 years old. We also know that, and this is interesting, in children, boys and girls, it's equally prevalent, but as you get more into adolescence, it becomes more common, much more common actually in girls. We could have a 2-hour conversation about that. Certainly, you know, some people have argued about the role of pubertal changes, environmental changes, the different challenges facing young girls, adolescents versus boys, how boys may hide it more and may express it more externally. You know, there's lots of different hypotheses, but it's clearly the case that in my clinic, we see equal numbers of boys and girls, but if I was running an adult clinic, I would see many more women. So it's an interesting thing. Ethnicity and race, again, we see it in all ethnicities and race. However, having said that, I told you yesterday we have the majority of our people that come into our clinic now are Hispanics, but we see very little African Americans. And we know that African Americans and other groups suffer from anxiety. And I don't know what we can do more to get to outreach to African Americans, to have them come in. But it is something that's been reported in the literature that their attendance at these clinics. What's that? Well, I set up a satellite clinic at the Biscayne Bay campus. And I had an African-American graduate student setting up the clinic, and she went to many schools to reach out, and we just had a really hard time. And actually, you know, for those, you know, for some of you in the workshop, if you have ideas on this, you know, I really would like to hear more about any of your thoughts about that. Now, having said that about ethnicity and race, I do want to say we actually did publish one paper, and what we did find with Hispanic Latinos is that they do express their anxiety more somatically, and they report more symptoms of somatic complaints, and they're more likely first to go to a pediatrician and talk about somatic problems and complaints before they come and say they're nervous and anxious, and we documented that empirically. So that's, for those of you working in health settings, you certainly see more health and somatic problems with Hispanics in their expression of anxiety. I believe there's also more stigma. I think there's stigma all over about getting mental health services, but I believe there's even more stigma in the minority populations to get mental health services. Socioeconomic status, it's again in all classes. Marital in families, it's in all. It's not more common in divorced or single parents, nothing like that. Family size, and the parents do tend to be high in anxiety, and they also tend to have some depression as well. So that's sort of like the demographic factors of anxiety. So I already told you how it's prevalent, but it is the least detected and referred. And that's been empirically shown. I said in Norway, that's been empirically documented. And again, this is the reason, you know, that's that internalizing, externalizing distinction. The kids who cause the trouble get our attention. You know, the kids who are suffering in silence, you know, aren't being paid so that much. And there's also an assumption that childhood anxiety is transient. The kids are going to outgrow it. I mean, it's amazing to me when parents come to us and the parents have been sleeping with the child in their bed. And everything I'm telling you, I don't, you know, as David Barry would say, I don't make it up. It's all true. You know, we see parents who have been having their child sleep with them because the child has so much separation anxiety. And if you ask them, it's amazing how so many parents will say, well, I just thought it's a phase. You know, I just thought they'll outgrow it. And so that is a really common assumption. All right, and so I do want to make a distinction about transient anxiety. We are not going to be treating transient anxiety. So this is what transient anxiety is. It's expected. It causes relatively little interference in functioning. It comes and goes. And it's associated often with new or unexpected events, like thunder, the first day of school, a big test. And it can be handled with minimal reassurance and encouragement. Okay, and that's not what we're talking about. So how many of you have your own children? Okay, isn't this what we do as parents? Right? You got it, right? It's okay. You can do it. Right. But the children we're going to be talking about today don't respond to that. If they did, then they don't need more attention. So anxiety disorders are associated with impairment. Okay, that's the key thing. When people ask, and when you guys need to figure out, because many times, you know, part of what we do at the Child Anxiety Program at FIU is, you know, much of our job is trying to figure out, do they really need us, or do they not? You know, is this something that can just be handled, you know, with very slight intervention? You know, just telling the parents, do X. You know, that's part of what we need to make a decision about. And so the way we try to figure things out is we talk about interference or impairment. And we ask about how is this problem messing things up for the family, with friends, with school, with personal distress. And we ask very specific questions about that. So could somebody tell me like how you would ask that question? How would you ask a question about that? How are things messing things up? Any? Right, okay, perfect. Does it happen every day? How severe is it? And so to me, so it's fish. You ask, how frequent is it? Does it happen every day? Oh, did you look at the slide ahead of time? Okay, no, no, I'm joking. It's okay. If you can cheat all you want. Once a week, once a month, how frequent is it? How often is it that your child won't let you leave the house because the child puts up a fuss if you do? How often is it that your child doesn't go to school because he's worried or she's worried about what the kids think about him? How often? And of course, the more frequent, the more it's likely to be interfering. Similarly, how intense, how severe is it? You know, how distressed does the child seem about that? And then, you know, how long has this been going on? With the DSM, there are time duration criteria. And it's usually, for some of them, like for some of the disorders, like separation anxiety, most of the criteria is 6 months, that you need to have these problems going on for 6 months for it to be considered a disorder. So this is an important thing to be looking for, to go fishing for impairment. And you know, we use a rating. You know, we like to get a rating of, and that's in the workbook. And it's great to ask, you know, even John Lockman was talking about an anger rating. I think quantifying things and asking them, well, when you have to do X, how much does that bother you? How much does that make you feel nervous? How much does it make you feel scared? And explaining the 0 to 8 scale. You know, and again, I used to have like made-up thermometers, you know, big thermometers that I would make a joke to the kids, you know, like I can't stick this over here and I can't stick it over here, but can you at least point and tell me, you know, how you feel? And, you know, they can really relate to the concept of a thermometer. And this is actually interesting because, you know, I am going to be talking about diagnosis and differential diagnosis, but in fact, what you usually find is that it's more common for kids to be impaired. Oops. It's more common for kids to be, right, you got that. It's more common for kids to be impaired and not necessarily diagnosed. And this was a community mental health setting, and they looked at all the kids that are coming through clinics, and what they actually found was that you have more kids who are showing impairment but are not necessarily meeting all the strict DSM diagnostic criteria. And so I think for those of you who are working in settings where you must have a diagnosis, that can pose a problem for you because it's really not so much the diagnosis, but it's the impairment. So I guess, you know, I wanted to make that point. Does anybody have, I mean, how many of you are required to do diagnoses? Oh, all right, not that many. Okay, all right. What's that? For insurance. How many of you are required to give a diagnosis? Yeah, how many, raise your hand, yeah. And so what do you sometimes just write, what do you okay, yeah. You mean you kind of like, yeah. Okay, because in fact, not all the kids necessarily are meeting the diagnostic criteria. So it is important. And when you look at the types of impairment that kids are presenting with, many times it is the anxiety are the most common areas that they're showing impairment. All right, and I already showed you this yesterday as well. But I think this is really important, not just because it highlights why it's so important to treat anxiety. You know, I do believe that treating anxiety in children is like a prevention program because it is so common, it is so prevalent, and because it becomes, you know, one of the earliest disorders. And because we know that if you don't treat these disorders, most people are going to continue to show anxiety, other anxiety, and then, you know, this gateway, you know, it's rare to find a depressed person who is not anxious first. And it's more common that substance use is followed by depression. So it is this gateway phenomenon. So I do believe that. And again, if you ask adults, you know, who suffer from anxiety, the majority of them will say to you, I've been this way all my life. They're not going to say I became this way when I was 35. You know, most of them are saying they started somewhere in childhood or adolescence. So that's one reason why it's so important. It is really a prevention problem. Now, the other reason why it's important to know this, not just to highlight the importance of it and the preventive value, but the other reason is when you're working with children, knowing this general developmental pattern helps you. You know, if you've got a 5, 6-year-old, 7-year-old, you know, you're more likely to be starting to think of these disorders. And as you get more, you know, into 9, 10, 11, you know, here, and as you get more into the teens, you're thinking more of this. I mean, you know, it's not carved in stone, but I'm just making the point. If I see a 6, 7-year-old, I'm more likely to be thinking the separation problems than the generalized anxiety problems. You know, the generalized anxiety starts happening later. And the same is true with panic disorder. It's something that you see much more into adolescence. Yeah. Yeah, I mean, I don't know. I mean, I can tell you we have treated, I mean, we've treated at least 3 children who couldn't wear certain clothes. And they couldn't wear certain clothes, and they, you know, and I even published a paper, believe it or not, in the journal American Academy of Child and Adolescent Psychiatry. It's a good journal, and it was funny. I don't know if some of you know the journal, but they have the listing in that journal. They list 3 or 4 highlighted articles in the cover page, and I always made the joke I was the cover girl because my title, this article got on the cover. We treated a child with a button phobia. It's published. I mean, you could look it up. You know, and the child would not wear anything with buttons, and it was a problem because he was in a parochial school, and they had to wear, you know, the shirts like this, and you know, pants, and it was a big problem. And again, and we have girls who only wear big baggy clothes, but we treat it with exposure.
So that's what they do with the sensory
Yeah.
stuff. If their loud noises bother them, they listen to headphones.
Yeah.
With the loud noises or cracking
Yeah.
glass.
So, you know, I mean, you can call it whatever we call it. I usually, when I have to give a diagnosis, I say specific phobia, and I give it a specific phobia diagnosis, and I treat it with exposure. Yeah. So I don't know. Is it sensory integration or is it a phobia? I don't know.
That's my question.
I don't know. I don't think. If I knew the answer, then I could win the Nobel Prize. What? Anxiety and depression? Well, the difference, I mean, anxiety and depression, you can tell the difference, and the main difference is both of them are characterized by negative affect, but depression is also the absence of positive affect. Whereas with anxiety, you have negative affect and some positive affect. With depression, it's negative affect and the absence of positive. And that's the best way for me to learn how to differentiate. So when I work with a child, I mean, you know, a lot of times it's mixed, but if I ask them, well, you know, what are some of the things you like to do? An anxious child can still tell you some things. You know, they still get some pleasure from things. A child with depression or an adolescent with depression, it's an absence of positive. You know, the world is negative, their selves are negative, the future is negative, and they just don't find pleasure from things. So that, I think, is a really useful way of distinguishing anxiety and depression. Now, of course, I don't have a slide, and I guess I should. It is more common than not that there's comorbidity, co-occurrence. It is rare to find just one problem. If the most common single diagnosis, if we do find, might be a phobia. You know, we do have kids that come in with a phobia of dogs or a phobia of elevators. But even then, they might have other problems. But otherwise, it's really common to have co-occurring disorders. And most common is to find that social phobia and generalized anxiety disorder are co-occurring. Of all of them, they co-occur the most. And I think this was really an important study that we recently published, because I think most of us always think of depression being associated with suicidal ideation. Now, we don't know if anxiety is associated with suicidal behavior. Nobody's looked at that, but at least we were able to document that after you remove all the stuff relating to depression, you still find anxiety predicting quite highly suicidal ideation. And I think that's a really important finding. And I also know that with adults, that it's common to find panic disorder in adults being highly predictive of suicidal intent. So we just don't know about that in kids. Okay, and as I say, successful implementation depends on conceptualization and understanding of the child's problem. And so now I do want to now spend some time on diagnosis and assessment. And I think, and the reason why this is important, let me go back, is when the essence of the treatment is, in my opinion, exposure. I say in my opinion because some people emphasize doing the cognitive work much more and then exposure follows. I personally like to do the exposure more and then have the cognitive work follow. And we'll talk more about that. And that's why it's really important to understand and conceptualize the problem. No manual is going to do that for you. No manual can do that for you. That's where it is up to you to know a little bit, maybe more than a little, about anxiety and what they look like and how they're different from each other, because the essence is, what are you going to expose the child to? And you need to expose the child to the appropriate situations and objects. If not, it's it's like trying to fix a foot and you're going for the arm. You got to target. It's targeted. It's a targeted treatment. Okay, so these are the disorders. So as I was saying, this is the only one that's now classified specifically for children. All of these other ones are found in children, adolescents, and adults. And the criteria and the characteristics are the same. All right, there's no differences in how they're described in the DSM. I also want to make the point that these diagnoses and this classification has been empirically validated. Initially it was based on clinical consensus. A bunch of psychiatrists sat around and said, oh, I see a kid that looks like that, I see a kid that looks like that, and they put it in the book. But since that time, there have been very good studies using factor analysis and other complicated statistical approaches to show that these are basically distinct problems. But as I said, there is a lot of overlap, especially with social and generalized anxiety. There, the correlation is very high. So let's just go over some of these cases, and these are all real cases, just so you get a sense of what these kids look like. But so Sue is a 4th grader. She stopped attending school. She went the first couple of days with a huge fuss in the morning, which continued for a few hours in the classroom. Parents were told, and these are all true, I didn't make these up. Parents were told that she can't stay in school if this is how she's going to behave. Now things have gotten worse, and she refuses to even get out of bed. She vomits at night, reports having terrible stomach aches. She's afraid to sleep alone. She's been sleeping in her parents' bed for over 2 years. Okay, so without doing an interview of this child, and without looking at the slides, what problem do you think this is? Right? Right? And the reason why it's in this red is because this is to show some of the external stuff that you see. Even though it's an internalizing problems, you do see externalizing features, and that's that. And there's separation anxiety for you, okay? And this is probably the most common of the anxiety disorders, and again, with the younger kids. Kevin has just transitioned to from elementary to middle school. He's also showing increases in absenteeism. When questioned, he says that he can't handle the idea that kids are probably laughing at him behind his back. He says he hates having to walk through the hallways between classes, knowing other people are looking at him. He worries constantly what other kids are thinking about him, and he's worried that he might say or do something dumb. Okay? What is it? Social phobia? Right? Okay, and there you got that. All right? Now, you know, when I said there used to be an avoidant disorder used to be that you just stayed away from people. But what makes social anxiety, and they got rid of it because they said, you know, it's not just that you stay away from people, it's also that you worry about what they think about you. So it's that social evaluation concern. Okay? And I have to tell you, this is, I think, you know, really tricky sometimes, especially with the young adolescents, early adolescents, because, you know, a lot of kids are really worried about what other kids think about them. You know, and I'm gonna go out on a limb and say I actually think it's more with the girls than the boys. I mean, but that's just, you know, been my clinical experience. That, you know, and a lot of it has to do with how they dress and how they look and all this stuff. And it gets really difficult sometimes. So that's why you have to go back to that frequency, that impairment. How is it interfering? You know, somebody told me yesterday about his daughter. Somebody was telling me about, you know, it got so bad that the kids stopped going to school, you know? I mean, and that's when you start seeing it being so bad. I mean, I've seen many kids get referred to our clinic because they're stopping going to school. And you might think it's a separation anxiety, but many times it's the social anxiety. It's intense, the social anxiety. Okay, did somebody, yes? You know, that's an excellent question. And would somebody like to take a crack at that? I'm not trying to deflect it, but I'm curious to hear other people's reactions to that. When is it social anxiety versus, quote, paranoia? Like, you know, what's the difference between being socially anxious versus being paranoid? Does anybody have any thoughts on that? Yes, Linda. Yes, and I think I actually do think Linda hit the nail on the head with this idea of it being more delusional, you know, and getting a little bit more intense. But I have to tell you, I've had so many weird examples of things, like kids saying, you know, I don't want to eat in public. Okay, I can get that. That's social anxiety. But then they say, but I'm afraid if I eat in public, it's possible my pizza's been poisoned. Or they don't want to eat in a restaurant because they think the food is being poisoned. And I actually you know, whenever I don't know anything, I have one of my students, you know, Lyndon can vouch for that, right? I have one of my students go do a lit search and say, tell me what's been done in the literature in terms of the differences between irrational thinking versus delusions. And what's very interesting is that the research is ambiguous in terms of whether or not it's a continuous, is it a quantitative difference? Is it just a matter of continuous, you know, or is it qualitatively differences? And we really don't know, like, you know, if it's a qualitative or a quantitative difference. But I agree in the way you characterize that. But it's certainly, you know, something to be thinking about. So thanks for that question. And then Antonio is worried about the FCATs. On Friday, that's the Florida Comprehensive Test, the big high stakes test. On Friday test days, the teacher notices that he looks upset and almost as though he might break down and cry. He reports a fear of not being able to move on to 4th grade if he does poorly on the FCAT. He constantly asks his mother and father for reassurance that he won't be retained. No matter what he's told, he still worries. But he's performing satisfactorily. He's a fine student. But he's still often absent on and Fridays, especially with headaches. People are shaking their heads, so you know I'm not making these cases up. It's called, okay, and what do you call it besides FCAT phobia? What is it? It's actually generalized anxiety disorder, okay? I mean, I gave the example with the FCAT, but if you probe further, it would be, well, what do you think will happen with the FCAT? I won't move forward, and then I won't get into the next grade, and then I won't get into the next grade, and I won't go to college, and it gets into a whole, what's that? Excuse me?
D made it to your clinic, there's 1,000 others.
There's about 3,000 others.
So sad.
And I'm going to talk more about that because I have some interesting data to share with you on that. Yeah.
But I was just wondering,
No, go on.
what kind of questions do you ask the parents? Because how do you know that the parents are not putting a lot of pressure on the child? So it's not so much that the child's worried irrationally, but he has, the parents.
Well, certainly we've talked about, yes, and we're going to talk about this. Certainly the parents play a role in maintaining these problems. I mean, there's, a lot of times. I don't want to blame the parents, but certainly, but the thing is you can have parents who put a lot of pressure on kids, but they don't develop generalized anxiety disorder. So some of the more kids are prone to that. Yes?
For this particular case, it seems like a test anxiety, even though it's generalized in how it plays out. Is the thought that for this student, if it wasn't tests, it would be something else that he'd be anxious about?
The main difference, and I'm going to talk more about that. This is an example of that, and you're right. The way it's presented, it could be a test anxiety. However, he has other things. He also has the headaches, but also he has other things he's worrying about. I just didn't put it on the slide. But there's no such thing as test anxiety as a diagnosis. That's why the diagnosis tends to be more generalized anxiety. And so the example I gave was a little bit too specific on the FCAT, but if you would ask him, and if he was to be telling you about the global warming and about the terrorism, and if he was going to have stomach headaches, this is an important thing now with GAD, having some of these physical problems. And then these are some of the common worries that these kids are having: making mistakes, worrying about little things, worrying about if I could be thinking, gee, I didn't have those cartoons yesterday and I had to improvise, and I hope I didn't look like an idiot, and I hope I was okay, and I hope da-da-da, and then having to do, which I did do a little bit with my students, was I okay? Okay. And getting a little bit of that reassurance, was I okay? And they all came to me. I reinforced that behavior in my students to come to me and they go, okay, we better go and tell Wendy she was okay. So, I'm not going to lie, okay? So, but I have it under control. But I have some of that, and I'm sure a lot of us have some of that, and we certainly probably have children who have some of that. But again, I'm functioning, I'm a professor, I'm able to do things. But the people who are not functioning, or are just totally like a basket case, if I couldn't sleep all night, and if I was having a terrible headache about it, and I was just ruminating and unable to stop that worrying, that's the GAD. Okay, now this is related, I think, somewhat to the question you were asking about the test anxiety, but not quite, because I do want to talk a little bit about the differential diagnoses now. And again, this becomes relevant because of the exposures. So what is it that makes a social anxiety different from a generalized anxiety? And usually the worry of social it is focused on performance and social evaluation. And GAD, you have that too, but it's not just that, okay? So if you have mainly the one area of worry about the social evaluation and the concern, then it's social. But if it's other areas of worry, then it's GAD. So that's important for you to know because, Vera was talking about wastebasket diagnoses. Too many times, people right away assume generalized anxiety. As soon as they hear about worrying, they say generalized anxiety, and that's not true. Generalized anxiety is beyond the social anxiety, or it's beyond the separation anxiety. Okay, so that's what makes that different. And the worry does not, and the anxiety dissipates upon or avoidance or escape of the situation. So if I had a social anxiety right now, I would be out of here. I would stay away from doing this task of speaking in front of you because I'd be so worried about what you think about me. And then once I'm out of here, I'm out on the beach and I'm having a grand old time. But if I had GAD, I'd still be worrying about it even if I'm out of here. It's a more cognitive type of process. And that also becomes more relevant because with the treatment, I personally like to treat separation anxiety or social anxiety more than GAD. Why? Because I can do exposures more easily with the separation of the social. GAD, and we'll talk about examples of exposures. I'm not going to give you some good ideas about how you can do exposures with GAD. Nevertheless, you still probably need to do sometimes a bit more of the cognitive work because it is this type of uncontrollable worry. And with social, they have trouble making friends. And this is not really true. You know, I told you some of these slides are not exactly mine. So I actually wouldn't really put that in. I would probably say not as much. But you still, I mean, peer relationships going to be a problem with all these problems. But certainly with social, you would think that it's going to be even more. And that part is true. And this is really, this bottom part here, I believe is what is the most important well, it's not, another really important difference. With social, I'm really worried about what you think about me. So, you know, like, you think I'm stupid, you think I'm dumb, you think I'm stupid, you think I'm dumb. Why was it always that one? Okay. With GAD, it's more, I'm not living up to my standards. You know, I think I need to be perfect. I think I need to do a really good job. So there is that difference with the social being more what you think about versus the GAD, it's themselves. And that's also with kids, because you know, you asked about the parents, you know, the parents who are putting the pressure. Sometimes the kids have, you know, just worrying about themselves. The kids are worried the teacher will think I'm dumb. The teacher won't approve of me. My parents won't approve of me. Versus the kid who says, if I don't do this, I'm not going to perform, I'm not going to move on in school, I want to go to college, I want to be a doctor. That's the more intrinsic stuff. Okay, and again, this might seem trivial, but I don't think it seems trivial. This is why it's important, because when you treat these children, you need to ask lots of questions. You know, you need to ask, don't assume anything. You need to ask, well, if you don't do so well in this course, in this subject, what does that mean to you? And if they say to you, well, my mom is going to kill me, or I love this teacher, and the teacher always thought I was so smart, and I'm going to disappoint the teacher, then it's more what? The social. And then what it means when we do exposures is you're doing exposures where they're faced with being evaluated by other people, versus if they say, well, you know, I want to be a doctor, and I'll never be a doctor if I don't do well. And, you know, and they start worrying about, you know, what it means for them. So that really is the most important, a very important distinction. And I can't emphasize enough the importance of asking questions intensely to try to conceptualize what you think is going on. Oh yeah, no, I said of all the anxiety problems, this is the most comorbid. Because a lot of times you have a kid who has this problem, and then they have other areas. So then they have social and the GAD. So it's the most common comorbid occurrence. And I'm actually really sorry that I didn't begin with asking if there were any questions from the last, before the break. Are there any questions? Okay, somebody did ask me a really good question about the gateway thing. You know, when I put those disorders, specific separation, and she asked me, well, does that mean separation could be a gateway for social? And the answer is yes, because that's sort of like the developmental pattern that you see. So as I said, it's more common to see the separation anxiety, and then a few years later, they'll grow into a social. You're never going to see a child with panic disorder go back and become separation anxiety. The separation anxiety is coming first. You know, so there is that pattern. So each of those disorders are kind of gateways, but, you know, not carved in stone, but generally speaking. Okay, and social versus separation. Avoiding social situations because the child does not want to be separated from the parent. All right, that's SAD. Versus the child who stays away because of fear of social evaluation. So, like, can you guys think of examples like that? Like, can you think of an example of someone who who maybe is not doing something. Yeah. Exactly. Birthday parties. You know, those kids who always, I remember, like, as a parent, you kind of like stay at some time, at the party, but at some point it's like, okay, great, I have 2 hours. I'm going to get a manicure, and like but it really sucks when the child says, no, you got to stay with me during the whole party. Then you then that is suggesting that it's more a separation anxiety, and and there are many kids we see who the parents have to be at every extracurricular activity with the child, and and a lot of times those are the kids with the separation anxiety.
And they'll ask first.
And they'll ask, yeah.
Are you going to go too, Mom?
Yes. Are you going to go too, Mom? Right. Right. And that, is a really important distinction to ask. And again, it has clear implications for what you target with treatment. Yes.
I was just going to ask.
Oh, I'm sorry, but the microphone. Okay. Yeah.
With GAD, because the worry is such a central component, and so cognitive abilities, are required to worry. How early would you say GAD typically comes about? And also, if a child isn't reporting worry, but they're showing some of the other symptoms, is it still okay to diagnose GAD, or does the worry really have to be reported by the child?
I mean, GAD can get diagnosed as early as age 6 and 7. I mean, it does. I mean, and some kids are just, cognitively advanced, and they're able to have those worries. And some of the times, they have GAD, but they're not expressing the worries. But if you probe enough, but if they're having other symptoms, the physical symptoms, sometimes it's the temper tantrums, are really their way of expressing worries. So it could begin at an age. It is challenging, though, sometimes to get at the cognitions of a young child. Okay, and now before I do that, I had some slides on panic, but I decided not to do that since there's another thing going on panic. But I do want to make the point that panic disorder is also something that we see more in adolescents. And the important point I want to make about this is all of the anxiety problems can be associated with panic attacks. Okay, so if you have a phobia of a dog, you can have symptoms of panic. What are symptoms of panic? Palpitations, sweating, derealization, trembling, thinking that you're going to die, thinking that you're going crazy. So this is all panic attack symptoms, and you have that with all the anxiety disorders. Panic disorder is something where you have them for a certain amount of time, and they can occur with avoidance or without avoidance behavior. So what does that mean? That means you can have panic disorder, and you can be worried about having these symptoms, but you can go and do everything. But you're just worried about it, and then you get these attacks, and they just happen. But a lot more common, though, is to have panic disorder with avoidance. What does that mean? That means that you would be unlikely to sit where Maria is sitting. You would be unlikely. You'd be more likely to be sitting right there. Why? Because if she has panic disorder with avoidance, she doesn't want to sit there, because her main anxiety is she'll have an attack and I can't get out. And then what's going to happen? Well, part of it is she's going to be embarrassed, and that's why sometimes there's a social component to it, which is interesting. But also, she's also afraid she's going to die and something terrible would happen, and she needs to get out and get help and escape. So, and we see this in the classroom a lot. A lot of the kids, are sitting in certain places because they're afraid of getting some of these feelings in the classroom. But again, I'm not going to spend that much time on panic, since there's a whole other thing on that. Yeah.
How many of these anxiety disorders are genetic?
All of them. And I have a slide on that in a minute, okay? Yeah. Okay, so that was panic. Now, and these are other common problems, and I told you selective mutism, which is probably going to be an anxiety disorder, and I also want to talk about school refusal, and I also want to talk about test anxiety very briefly. Okay, so this is what selective mutism is. And I am certainly seeing an increase in selective mutism being referred to my clinic. I have no idea why, but certainly it's been an increase in my referrals. And so these are kids who are not speaking in situations such as school. It starts interfering with their functioning. The symptoms must last at least a month. It's not due to a lack of knowledge or comfort with spoken language, and it's not due to other communication disorders or PDDs or psychosis. And some people have talked about there maybe being subtypes of selective mutism. There's some kids that tend to kind of look more like this, and that's why I think it's a little controversial about whether or not it should be an anxiety disorder, because some of the kids look more like the orange, which would be a more anxiety subtype, and that's true. But you also then see this other subtype. And in fact, we actually did publish a paper on the kids who present at our clinic. And we documented that we found, and the younger, if I remember correctly, the younger kids tended to have a little bit more of this oppositional component, and the older kids who were a bit, as they got older, they were more like anxious. And then, there's also, of course, there's also that myth that all kids with selective mutism have experienced trauma, and that's not true, but certainly it's true of all psychopathology that there's always a chance that there's a trauma experience, and there is some kids who probably fall under that subtype. And this is just an interesting slide about and I think these are the kind of data that people used for the DSM-IV, where they found is selective mutism a more severe form of social phobia. And these were kids with selective mutism, and as you can see, they, the majority, except for this study, where it was 44%, all the other ones had more than the majority had also meeting for social anxiety. Now, of course, it's kind of hard to do this because when you ask the kids the questions about social anxiety, they don't talk to you. But what we do is we usually have them point yes or we have them point to cards yes or no, and point on the feelings thermometer. But but that's partly why I think they're thinking about making selective mutism an anxiety disorder. School refusal behavior, I don't like to call it school phobia, which is the old-fashioned term. And the reason why I don't like to call it school phobia is because it's not a phobia. It could be a phobia, but it could be just all the other anxiety problems. So when we talk about school refusal behavior, it's kids who completely or who are partially absent from school, or who show morning misbehaviors to avoid school, or they attend school, eventually they get there, but they're suffering. In my view, these are all cases of school refusal. And if they're, and what we know about that is that it's also prevalent, like about 8% in the population. Again, equally seen in boys and girls. That's the most common age, and it's also more common among minority populations. And it's also more common in hostile school environments. I should also make that point as well. But what's important, again, is the heterogeneity. And this is important when you treat a child refusing school. You have to ask them, what is it about school that makes it hard for you to attend school? Because you can ask you, and you're going to get a different reason. For you, it could be, I don't want to leave my mom. I want to stay home. I'm afraid if I go to school, something bad will happen to her. I don't want to go to school because those kids are going to make fun of me and I don't want to have to give a presentation. I don't want to go to school because I'm just worrying about everything that might be happening there. The school can go on fire, we're going to get a terrorist attack, the kids are going to make fun of me, the whole gamut. Or it could be something very specific. It could be a very specific phobia. I don't like the sounds of the bells. The bells bother me, they're too loud. So assessing for that is important because It is so heterogeneous. And again, it could be also, or panic disorder with agoraphobia. I can't go because if I go, I may get a panic attack and I'll be embarrassed and I won't escape. Yeah. I know I'm speaking more about the anxiety related. Now, but you raise a good question. When someone is not going to school, the first question to ask about is how is the child doing academically, and what kind of learning problems does the child may or may not have? Because it might be that the child is not attending because they're not doing well academically, or the schoolwork is too challenging and they're not able to keep up with it, and that's leading them to have anxiety. Would I treat the child for anxiety then? Not really. I would probably then go and get some assessment done, go to a school psychologist and find out if they're not in an appropriate placement. And they need to be in a more appropriate classroom setting because they're totally lost in that classroom setting. But anyway, so that's an important thing about the school refusal, because many times it is important to make sure they're not avoiding out of the frustration of the academic work. And this is true of test anxiety, tend to really high. And girls, in this case, are reporting higher. And also African Americans are reporting higher. And again, there's no diagnosis of school phobia or school refusal, so it's one of those anxiety disorders. And with test anxiety, there's nothing in the DSM for test anxiety. But it could be one of the anxiety disorders. I need to be perfect. I won't get into college, GAD. Others would think I'm dumb. Social, taking tests, making me scared, and it's only tests. And you ask them, and you ask them, and the only thing they tell you, no, it's just tests. It's just tests. It's not usually. It's usually more the GAD or social, but it's something to keep in mind. And then I may get panic attacks. And again, I'm highlighting this because it has clear implications of how you conceptualize and how you're going to treat the case. So you don't go to school on Friday because you're afraid of the test. Well, what is it about it? And depending on how they answer that, you'll treat it accordingly in terms of what you'll target. Now, this is what I wanted to say to you guys, because I think you'll find this really frightening, is we have a paper and that's going to get published, but we've just had to make a lot of revisions in the Journal of School Psychology. And we found in a sample of African American school children who reported high levels of physical symptoms of anxiety and social anxiety, also reported high levels of test anxiety. And the kids with the high test anxiety had low achievement levels on the FCAT reading. And this is the first empirical demonstration I know of to show, because we were able to get FCAT scores. And this is the first demonstration I know in being able to show that if you have anxiety, that can lead to test anxiety, and also is related to test anxiety. And test anxiety is then mediating low achievement levels on the reading. And yesterday I talked about directionality. When we reversed the path, meaning when we looked to see if the poor FCAT score was making the kids anxious, no. It was the anxiety predicting the FCAT score. The FCAT scores were not leading to the anxiety. So I think this is a really powerful thing, and I think I still heard these findings last year. We're still working with this journal to get it published because it's a really hard journal. Journal of School Psychology is really top notch, but they want to publish these findings because they're so important, and I think it has really important implications, totally, because it's basically saying, yeah, these kids with the this FCAT stuff is serious stuff, and the kids who are not doing well, a lot of them, really are anxious, and this anxiety is messing up their scores.